Welcome to Docs on Call, brought to you by Fort Wayne Endocrinology.
Good evening. Glad to have you back again on the program. I'm Lee Kelso. Tonight we're going to be talking with Dr. Ashok Kadambi from Fort Wayne Endocrinology. We're going to be talking about something that affects many people, and that is thyroid disorder. Thyroid is a gland in your body that is the predominant regulator of your body's metabolism. So when something goes awry with your thyroid, you feel it in a number of ways, and that's what we're going to explore tonight. We invite your calls and questions at 483-8331, 483-8331. I think you'll recognize Dr. Kadambi from his last appearance on the program. Good to see you back again.
Well, thank you for inviting me back, Lee.
Glad to have you. So let's talk about the thyroid more broadly. I mentioned that it regulates our metabolism, but more broadly describe for me what role it plays.
Well, believe it or not, thyroid was one of the original hormones, one of the first hormones ever to evolve. When life as such grew out of the ocean to the land masses, the body needed, the animals needed a source to trap the iodine, and one way to do that would be to manufacture thyroid hormones. In fact, thyroid hormones are so important that if you deprive a tadpole of thyroid hormones, it does not metamorphose into a frog. It just stays a tadpole.
So it's absolutely critical to our
absolutely
development.
critical for life.
Yeah.
Okay, and virtually every cell is affected by the thyroid, right from your cells of your hair to the tip of your toes, to your brain cells, to your digestive system, you name it, every system is affected by thyroid.
Now, we were talking earlier about the fact that even though your blood test may show that your thyroid levels or your hormone levels are in the normal range, that doesn't necessarily mean that you're not symptomatic. And we're going to talk a little bit more about that in just a minute. But I want to start with some anatomy. So I know the thyroid is below my voice box, right?
That is correct, Lee.
And show us a little bit more about what's a normal size and some of the other conditions that can occur.
I have some props here with me today, and do you want me to just sit it here?
Yeah, just leave it there if you would.
If you look at the thyroid gland, this is an actual thyroid gland. This is about what it is, okay? I'm going to put it right over the tray or the windpipe over here. It wraps up beautifully around the windpipe, and it looks like a butterfly. This is your right wing, your left wing, and then this is your
I'm going to rotate it just a little bit. Let's turn him in that way.
That part? Okay, there you go. So the right side, right, left, and bridge that joins the two. Okay,
and that's
this is way below the
size.
voice box. This is normal. This is actually size. This is a normal size thyroid. Okay? Now, what happens in a disease state? What happens if the thyroid is overactive? We call that Graves' disease. This is what it looks like. So normal size weight is about 15 grams. This would be about 60 or 75 gram size, or even 100 gram size. It's way enlarged, and you see all the blood vessels here, the vascular. This is a highly vascular or enlarged goiter, typical of Graves. There are no distinct lumps there. It's just what we call diffusely enlarged, and this is typical of what we find in a condition called Graves' disease or Graves' hyper (HYPER) thyroidism. Okay. Now there's yet another condition called multinodular goiter, where the gland is it's got multiple lumps and bumps, multiple nodules. Usually these are not cancerous, and these are more a cosmetic thing than anything else. Sometimes it can compress the vocal cords and give you problems with the voice, etc. But for the most part, these are benign. Now, a thyroid cancer is kind of rare, but this is what it would look like. One small little nodule on the side over there, that's your thyroid cancer. Okay, that is what it looks like. A single nodule is more likely to be cancerous. Multiple nodules, very unlikely to be cancerous.
So am I likely to feel that enlarged thyroid? At what point and am I going to notice it when I'm taking care of my cosmetics and dressing, that kind of thing?
Yes. Oftentimes the patients themselves will come to me and say I felt a swelling in my neck, okay? And that's what sort of clues the doctor into looking into the thyroid problems. The swelling in the neck is usually noticed when a patient showers, or in the case of a gentleman, when the person is shaving, might see a lump in the thyroid, or thyroid may be enlarged, and then that sort of prompts a phone call to the doctor.
But more importantly, more often actually, patients see you because they're feeling a set of symptoms that can be really masking many different things.
That is correct. The symptoms one of the problems, Lee, with diagnosing our our underactive thyroid is the symptoms are very vague. They're very universal. I call them the symptoms of life: fatigue, okay, just tiredness, weight gain, depression. This is common for in a lot of patients, and also high cholesterol. Sometimes the high cholesterol may be a manifestation of actually low thyroid levels.
Huh.
So it's got a wide range of symptoms, but most commonly these are called vague symptoms. Or what I used to, when I was a baby endocrinologist, I'd hate seeing these patients with chronic fatigue because I didn't know what to do for them.
Sure.
Now I know what to do for them.
So let's talk about that level of fatigue. You know, we all get tired and exhausted from time to time, but describe for me what somebody comes to you with.
Right. Everybody is tired from time to time. You know, if you've got an exam coming up or a test, something like that, you're studying, or a big project come up, you know, you've got deadlines to meet. Outside of that, if you notice something unusual over and above what we call normal fatigue, for example, I can tell you, give you an example. The patient I just saw this morning tells me, "Doc, you know, I had all these bounds of energy. You know, I used to come home from work, I'd do the chores at home, I'd stay up late, watch TV, you know, play with the kids, and go to bed at 11. Now, lately, for the last couple of months, I'm coming home at 5 o'clock, 4:30, 5, sometimes early, and all I want to do is crawl into bed." And that is unusual, over and beyond normal fatigue.
And you mentioned also there can be some fuzzy-headedness that can occur with that.
Right. That's also what we call cognitive decline, to use a big fancy word. But basically what it means is your brain is not working as well as it should. Okay? In other words, poor recall, you know, not being in the moment, not being focused, making mistakes at work, not remembering names when you were very good with names, not remembering phone numbers, not remembering to do your routine things, just what we call brain fog. Okay?
Those symptoms sound an awful lot like menopause as well.
Funny you bring that up, because a lot of the thyroid problems, the low thyroid or autoimmune, are autoimmune in nature. In other words, immune system affects it. So your immune system makes these things called thyroid antibodies that attack the thyroid, that prevents the thyroid from working. Now, in menopause, what happens is there's a precipitous decline in a woman's estrogen levels, and estrogens are very, very important for your immune system. So it sort of dysregulates your immune system, and then the woman would probably make a lot of thyroid antibodies, which would then affect the thyroid gland, causing it not to work well. So there's a cluster of low thyroid or hypothyroid cases around the menopausal age group in women. The other cluster is around puberty. So those are the two times when the hormone levels are shifting, is when we see a resurgence of thyroid disease.
Well, that might explain why the two callers on the line waiting to talk to us tonight are both women. So we'll jump out to the phones in just a second.
Good.
Dr. Kadambi just told me before the program began that we here in the Midwest live in what's known as the thyroid belt. Now, tell me more about that.
Yes, the thyroid belt. There are many reasons why this is called the thyroid belt. One of the big reasons is our soil here is very deficient iodine because we're away from the coast, from the sea. The other thing is the ice age. When the glaciers receded, it took away a lot of the minerals, including iodine, with it. And then of course the third reason, I think the more important reason, is what we call environmental toxins, including things like other halogens like bromine, which basically compete with the iodine and lower the iodine levels. So these are some of the reasons why this is called Midwest is known as the thyroid belt. You get all kinds of thyroid problems, including thyroid cancer, by the way.
So we're going to take your calls at 483-8331. If you have a question about someone in your family maybe suffering from a thyroid problem, or some of the symptoms that we've described for you sound like it might be a problem you're facing, you're welcome to jump on the line with your questions tonight for Dr. Ashok Kadambi from Fort Wayne Endocrinology. We're going to start the program tonight with Linda. You are first up for us this evening. Linda, go right ahead.
Yeah, Linda.
Linda? We're going to put you back on hold, Linda. We're going to move ahead to Lois then. Lois, let's get your question tonight for Dr. Kadambi. Go ahead. And Lois isn't there. There she is. Hello, Lois. Go ahead.
Hi. Thanks for taking my husband recently underwent a thyroid scan.
Yeah, you're breaking up on me, though.
Yeah, Lois, I'm unable to hear your question either. Let's try that one more time. We're obviously having a little phone difficulty. Let's go one more time. All right. If someone in control room wants to send me the message via text, I can get it that way until we get the phone problems worked out. The challenge that some people face around this gets back to an issue that I know you feel strongly about, and that is I go to a blood test and my test results come back normal, but I'm still symptomatic. How as a doctor do you face that challenge?
Okay, well, when you say normal, usually what I see is they do a single test called the TSH. Okay, a TSH is not actual thyroid hormone. It's more like a thermostat. In other words, when your thyroid hormones decline, your TSH levels go up. And the TSH is actually a signal made by the pituitary gland. So you're making the assumption that the pituitary gland is responsive to the thyroid hormones. In many cases, it is not. We see a lot of cases where the TSH levels are in the so-called normal range, but the patients have all the symptoms of low thyroid. Okay? In that case, we still treat them because they have symptoms and they have clinical deficiency of thyroid. This is the problem. If this is the TSH range is wide, for example, it ranges from 0.5 to 5 or 3.5. So if your TSH is 2.9 and you're very symptomatic, then you certainly need to be treated so that your TSH can come down to around closer to 0.5 to see if your symptoms get better. Now, conversely, TSH is not thyroid hormone. So I also look at what we call free T3 and free T4. If those are in the low normal range, they also need to be treated. We go a step further. We look at thyroid antibodies. If you have a large number of thyroid antibodies in your system and your levels are normal and you have a lot of symptoms, they definitely need to be treated. There is nothing wrong in treating a patient for 2 or 3 months to see if the symptoms improve on the thyroid. If it does improve, the patients feel better, there's no downside risk to it at all.
Well, interestingly enough, Linda's question that we couldn't get to on the air just yet, her daughter's thyroid antibodies are high. So is that a red flag? And tell me what the antibodies are. What role do they play?
Right. Thyroid antibodies, there are two kinds. One is the stimulating kind causing something called Graves' disease. The other is the blocking kind that causes underactive or hypothyroidism. And depending on which of these antibodies predominate, you get one or the other. So I suspect her daughter probably has hypothyroidism with the antibody levels being high, probably something called TPO or thyroid peroxidase antibodies. These are antibodies that attack a specific enzyme that makes the thyroid hormones in the gland, okay, it's called peroxidase. So these antibodies can be very high, and a high level of thyroid antibodies doesn't always mean the patient is hypothyroid. Okay, the thyroid levels could be perfectly normal, and I have a number of patients in my practice that I'm following, totally asymptomatic, no symptom at all. Okay, but the thyroid antibodies are positive, and over time they will decline. Okay?
I see.
Now, in some patients are not that lucky, the thyroid antibodies do harm. They destroy the thyroid and the thyroid levels go down and they get symptoms like fatigue, weight gain, hair loss, dry skin, constipation, poor memory, all those kinds of things.
And so the treatment is an oral medication.
Yes.
And there are several that you can choose from and you can prescribe. Is there any issue with being on them through my lifetime as I need to be?
Well, as long as you're regulating the hormones within what we call physiological range and you're monitoring for efficacy and looking for side effects, there is no harm staying on it lifelong. In fact, it is recommended that you stay on it indefinitely. Some patients over time will recover, and from time to time when you take them off the thyroid hormones, their glands will kick in and start functioning normally. But that's a thing that you need to discuss with your doctor and do that on a case-by-case basis. But for the most part, you're right, they need lifelong replacement with some form of thyroid or the other.
If I don't respond to one treatment, am I likely to respond to another? Do you need to kind of modulate and mix the two?
Right. I used to think in the past when I was a baby endocrinologist that replacement with levothyroxine or Synthroid or Levoxel will solve all your thyroid problems. That's not true. I've seen more and more in my practice that I need to do what is called a combination therapy, give patients a combination of the levothyroxine and something else called T3 or T4 and T3. T4 is levothyroxine and T3 is a fancy word for another thyroid compound called triiodothyronine. So this two, the body, remember, when you give Synthroid or your standard levothyroxine replacement, your body has to convert that into something called T3. So in other words, the T4 that we give you as pill is a prohormone. It's going to be modulated into something called T3. And a lot of times patients do not convert efficiently the T4 into T3. So therein lies the problem. So you got to give both these hormones.
Gotcha. We've got lots of folks on the line. We're going to jump back out to the phones and see how we do. Chris, we're going to start with you. Tell us your question for Dr. Ashok Kadambi.
Yeah, hey, I've had chronic hives for about 6 years. I get them on my neck, and they travel up to about the middle of my face, up around my nose and my jawline. And I've pretty much haven't had any success from my doctors telling me why is this happening. And my own research, I've read some interesting things about thyroid and that it can cause issues with hives and autoimmune problems due to thyroid problems. What are your thoughts on that?
Yes, the question is, what are my thoughts on patients presenting with hives and their likelihood of having a thyroid problem? It's quite high. You know, if you have a patient with hives, unexplained hives, and we ruled out all the other things, it's probably wise to look at thyroid antibodies. And usually the hives are correlated with high levels of thyroid antibodies. We do that routinely in our practice. We check for all kinds of antibodies of the thyroid. There are at least 3 or 4 different kinds. And almost always we find thyroid antibodies positive.
So there you go. It sounds like, Chris, it might be a good idea to have your blood tested, and you can do that at Fort Wayne Endocrinology. The phone number will be on the screen a little bit later in the program. And if you're just joining us, our guest tonight is Dr. Ashok Kadambi from Fort Wayne Endocrinology. We're talking tonight about thyroid disorders. Hypothyroidism means low thyroid output. Hyperthyroidism means high thyroid output. The low side of that problem is far more prevalent, although we'll talk a little bit about hyperthyroidism in just a second. Lois, you're up next on the program. What is your question for us tonight?
Hi, can you hear me now?
Oh, much better, Lois. Loud and clear.
Great. My husband recently had a thyroid uptake and scan. He was discovered to have a nodule in both the left and the right lobe, with the nodule on the left being larger, over 1.7 centimeters. The one on the right was smaller, slightly under 1. The radiology report revealed that the nodule, the smaller nodule on the right, had cold areas, but the radiology report did not comment on the nodule on the left. We have been advised that my husband should have the left nodule, as it is the larger one, biopsied, but we are curious as to why the radiologist would not comment in the report on whether that was a hot or cold nodule, and if, in fact, the right one should be biopsied as well.
Before you answer, hot or cold, is that in relation to the amount of blood flow? Is that what that's talking about?
No, actually, it relates to the amount of iodine being taken up by the nodule. If a nodule takes up very little iodine, we call that a cold nodule. If it takes up a lot of iodine, we call that either a isodense nodule or a hot nodule.
Okay. So as to whether this should be biopsied?
Yeah, this is a very interesting case. Normally we are taught that if the bigger nodule is what we call the dominant nodule, and that is the one, if there's cancer, it would be in the dominant nodule, so we need to biopsy the bigger one. But however, the cold nodule here is in the other opposite side. Most cold nodules are also benign. You know, it's not that just because the nodule is cold it's going to be cancer. The chances of a cold nodule being cancer is less than 5%. Okay, even in a cold nodule. I would re-look at that ultrasound, maybe about the uptake and scan, and actually get the pictures and take the actual pictures to the endocrinologist, or probably to the endocrinologist would be the best one to do it. Go with the actual picture so that I can actually visually see it before, because sometimes description is really not worth as much as actually looking at the scan. So I would look at the actual scan myself and then make a determination whether a biopsy is needed or not. Sometimes I would just do an ultrasound, take measurements, and just follow that over time.
So if it is a cancerous thyroid, you told me earlier that that's usually a very treatable situation.
Correct, 100% treatable. If you diagnose a thyroid cancer, you do what we call a total thyroidectomy, remove all the thyroid, give some radiation to get rid of the remaining thyroid, and you're 99% you're cured all the time.
Excellent. Rebecca, your question for us tonight, go right ahead.
My question for the doctor is, if you have like nodules on both sides that's pressing on your thyroid, if you're not having any type of thyroid activity going on, can that cause you to have thyroid activity?
In other words, can the nodules be big enough that it causes some local compressive symptoms? Is that your question? Does it cause compression in the neck?
Yes.
Yes.
Yes, and it's causing thyroid symptoms.
Yes, it can happen. That's definitely possible. So you'll have to look at the blood work, look at the scans, and see whether that's the issue or not. Oftentimes you'll have just local symptoms, local neck symptoms, but no real low thyroid symptoms like no weight gain, no fatigue, none of that. But there'll just be local symptoms in the neck, difficulty swallowing, feeling a tight collar, things of that nature.
Thank you for your call, Rebecca. Ginger, you're next on the program. Your question tonight for Dr. Kadambi. Go right ahead.
I have a question about my daughter and I just had blood tests, and they came back normal, but they also told us that we had goiter, and I was wondering what he thought about that.
Yes, a lot of times the blood test will be normal for goiter. So sometimes what we will do is we'll give our patients some thyroid hormones to reduce the size of the goiter. Okay. Often when you say normal, I'd like to see what exactly they mean by normal, because normal is such a wide range. So I would not completely discount treating you with thyroid hormones in that case.
Thanks for your call tonight, Ginger. Lots of people on the phone eager to talk to Dr. Kadambi, so we'll keep moving right ahead. Marcia, you're next. Go right ahead with your question.
Yes, I'm on Lexartan.
I'm sorry, on what, please?
I'm on medication thyroid now.
Okay.
And I've been having some problems swallowing and stuff, and I have constipation, and I was wondering if that has anything to do with my thyroid.
Yeah, in my experience, most patients are under replaced. In other words, they give them just enough thyroid to get by, but not enough to alleviate all the symptoms. So my suspicion is 90% of the time it is probably you need more thyroid. Now the other question is, what kind of thyroid do you need? Do you need a different type of thyroid? Blood tests and clinical exam will determine that. There are more than one type of thyroid, as you know. Synthroid or the levothyroxine is not the only game in town. There are other things we can use.
Marcia, are you seeing an endocrinologist, or is this being managed by your family care doctor?
Family care doctor.
Yeah, I would definitely talk to the family care doctor of maybe looking at other types of thyroid replacement. And many of them are quite knowledgeable in doing, giving you different types of thyroid.
Very good.
Okay.
Thank you, Marcia. Kathy, what's on your mind tonight? Go right ahead.
Oh, hi. I would like to know if you can explain a little more what central thyroid hormone resistance is.
Say that again.
Central thyroid hormone resistance.
Correct.
Thyroid hormone resistance. Okay. Well, there are some for any hormone to work, it must first bind to something called the receptor. Okay, and the receptor then initiates the sequence of events that makes the thyroid hormone work. So in some cases, the receptor, the thyroid hormone receptor, is faulty, and you need a lot of thyroid hormones, okay, for the receptors to be activated. Okay, that's one of the things. Then there are some cases where the pituitary gland, the receptors in the pituitary gland are faulty, so you have to have a lot of thyroid hormones to keep your TSH in the normal range, or to bring down the alleviate your symptoms of hypothyroid or low thyroid state. So in these cases, the blood test may be very, very high. You may have to push very high doses of thyroid to get the desired response. And we see this a lot in the Midwest. This is typical of the Midwest, called thyroid hormone resistance. And the amount of thyroid that's required for alleviating their symptoms are 5, 6, 10 times as much as normal people.
Thanks for your call, Kathy. Julie, you're up next. Let's have your question tonight.
Yes, I had radioactive iodine a year ago, and we're still having difficulty getting my levels back to normal. But the biggest thing I've noticed is that I have horrible neuropathy in my legs, and terrible brain fog and memory problems. Will that restore?
Okay, let me ask you a question. Are you on a preparation called, are you on something called Synthroid or generic Synthroid or Levoxil?
Julie, are you there?
Yes.
Yes.
Did you hear the doctor's question?
What type of thyroid replacement are you on?
I was on the Synthroid, and now I'm on the levothyroxine, 137 micrograms.
Right. In my
7 days a week.
Yeah. In my experience, whenever you've had radiation, what we call thyroid radiated, or even thyroidectomy or thyroid removed surgically, levothyroxine or Synthroid alone is not enough. You need something called T3, and that the other active form of thyroid hormone. You need a blend of both. So I would definitely look into adding a T3 to your regimen. The other thing is, why do you have the neuropathy? Because are we also dealing with coexisting other problems like autoimmune B12 deficiency? Because they also coexist with thyroid problems. You know, we're dealing with the folate deficiency. So we look at also the company it keeps. So not only do we treat the primary disease properly, we also look at what company it keeps.
Okay, great. Thank you very much.
Thank you, Julie. Chris, we're trying to get as many callers in as we can in tonight, so go right ahead. Chris, are you with us?
Yes, I'm with you. I'm sorry.
That's okay.
My question is, 20 years ago, I was diagnosed with Graves' disease. I have had radioactive iodine to kill off my Graves' disease. 20 years later, my Graves' disease has come back, and it's ophthalmic Graves' disease. Why did it come back?
Why did the Graves' disease come back and this time just attack your eyes, correct?
Yes, it's affecting my eyes now, 20 years later.
Yeah, to understand this, you have to understand that Graves' disease is not the disease of the thyroid gland itself per se, it's a disease of the immune system. Okay? So the same immune system that destroyed your, caused your thyroid gland to be overactive also produces these antibodies against the eye muscles. Okay? And they have now come back and they are now attacking your eye muscles, causing you to have the Graves' eye disease. Since you don't have a thyroid, you don't have the thyroid problem, I take it.
And we have to leave it there. We've run out of time, Chris. Bud, we know that you're on the line and have a question for Dr. Kadambi. He will take that for you off the air at the end of our program. If you'd like to learn more, you can always contact Fort Wayne Endocrinology. The website address is on your screen, FTWENDO, or you can contact them at 436-1248, 436-1248. Next time on Docs on Call, Ted Blanford from Summit Hearing Solutions will be with us. We'll be talking about better hearing and hearing technology. And of course, you can always watch this program online anytime you like. Just go to 21alive.com, look for the features page, and click on Docs on Call. Thanks for joining us tonight. Take good care of yourselves, and we'll see you next Wednesday here on Docs on Call.